Podcast is now starting. All attendees are in listen-only mode.
Hello, everybody. Thank you for participating in today's webinar on healthcare reform, provided to us by TriNet, Marlo Kusin. This is Veronica with Physician Partners, and I'd like to let everybody know that you are in listen mode only. And any questions that you have throughout the webinar, please feel free to type them in, and we will have them answered by Marla at the end of the webinar. And we will go ahead and start the webinar with a couple of poll questions to get you thinking about what this webinar will be about. And then we'll discuss the answers at the end of the webinar. So here we go with the first one. I'll give you about 10-15 seconds to answer that. Okay, so we'll go into the second question. And I'll go ahead and close the poll now. I'd like to introduce Marla Kusin. She is a member of the Senior Benefit Consulting Team with TriNet Passport. TriNet is a PRC corporate member here at Physician Partners in the Physician Resource Center. Marla has worked in the PEO industry for 17 years, holding a variety of positions that have been focused on benefits and the customer experience. She is a member of the Society of Human Resource Management and holds a New Jersey life and health insurance producer's license. Prior to accepting her first position with a PEO, Marla stated her working career in the insurance industry and held positions with a traditional insurance company, a third-party administrator, and construction company. Marla calls Dickinson College her alma mater, graduating with a BA in psychology. I'd like to welcome Marla to host this webinar. Thank you very much, Marla, and I'll hand it over to you.
Great. Thank you so much, Veronica. So good afternoon, everybody, and we're going to spend the next few minutes together kind of talking through the Affordable Care Act. So as we get started here, first let's talk about the Affordable Care Act at kind of a high level, and then we'll talk about some specific items that are coming down the road, different changes and different sections of the Affordable Care Act which are coming into play, and how those may affect your practice. So as we kind of look at the Affordable Care Act overall, the three policy objectives of the Affordable Care Act were basically to provide coverage to those who are uninsured in our country, to try to bend the cost curve downward. So I think that almost everyone will agree that the cost of health care and of providing health care is constantly growing and is becoming unaffordable for a segment of our population. And the Affordable Care Act was designed to be self-sustaining and not to increase the federal deficit. So if we look at the non-elderly population, and non-elderly is defined as those under the age of 65, the graph here shows the distribution of where people are obtaining their health insurance coverage. So 55%, just over half, are receiving or obtaining their health insurance coverage through their employer. We have 18% on Medicaid, 3% on other public avenues that provide health care coverage, 6% through other private insurance arrangements, and then 18% of that population does not have any form of insurance. So that 18% that is uninsured is really the focus of the Affordable Care Act. So how does the Affordable Care Act propose to get this 18% reduced and get them coverage? So the major resource there is the marketplace, which I'm sure you have heard about in some way, shape, or form. And that marketplace is both at the federal level and at the state level, and can provide subsidized health care insurance to people depending on whether they qualify. The second way to provide and expand health insurance coverage is to expand Medicaid, and that would be extended to those Americans who are earning up to 138% of the federal poverty line. If you are between 139% and 400%, then you are looking at the marketplaces and being able to be subsidized through that avenue. And then lastly, the Affordable Care Act also contained a requirement for employers to offer coverage to all full-time employees. And that is coming into effect in 2015. And there, as I'm sure you are aware, through the Affordable Care Act have been many delays or many modifications or transition relief that have been afforded as different deadlines have approached to try to make things attainable. So the employer mandate originally started for 2015 for any employer that had 50 or more worksite employees. That has shifted, and for 2015, the threshold to be considered a large employer will be 100 employees and should adjust in 2016 down to that 50 worksite employees. So in the public marketplace, the goal was for 7 million people to enroll for coverage. And in the late part of 2013, you can see that what was projected and what was actually enrolled was not at the target of and off by about 1.1 million members. However, the extension into 2014 and the improvements to the marketplace website ultimately had a projection of 7 million people being enrolled, and over 8 million people did actually enroll through the marketplace avenue. On the left here, you will see that estimates are that between 1.4 and 1.9 million of those people who did enroll through the marketplace did previously have insurance. So that always leads us to the question of, our goal was to reduce that 18%. We certainly hope that we are achieving that number as we go through this exercise. One of the other points that you may have heard in the press was, yes, we had 8 million people enrolled, but then there's a next step, and that is that people do actually have to remit premium for that coverage in order for it to stay in effect. So completing an application is the first step, and then actually paying for that coverage would be the next step to really start to effectively reduce the uninsured population. So Medicaid was also another significant component in the campaign to reduce the uninsured. And right in 2013, we had about 48 million Americans who were covered under Medicaid. There were an additional 3.9 million Americans who enrolled for Medicaid in 2014 through the marketplace. And more than half of that 3.9 million Americans were in states that did not expand their Medicaid offering. So from an ACA compliance perspective, I'm sure that your practice has wants to be sure that they're on point and on target with being compliant with the ACA. So for what should be currently in place right now is offering a summary of benefits and coverage, or an SBC, that should be available for all medical plans that are being offered. This did start in 2013, and a summary of benefits and coverage provides details of the medical plans in a standard format. The federal government designed a template. They like to say it is a 4-page document. I like to say it's double-sided. So there are really 8 pages of information that are available in a universal format. So what's nice about that universal format is if you have a husband and wife, or you have 2 people in a household that both have access to insurance, and they're trying to compare their options between those 2 different sources, they now have a document from each of their plans that will help them compare those plans and decide which option may be best for them. In the past, every group laid out their information a little differently, and that certainly could cause confusion or frustration in trying to really determine what does each plan do and what's the best choice for us. The other requirement under the ACA was a marketplace notice, and that marketplace notice needs to be provided to all new employees. Again, the marketplace notification requirement came into effect in 2013, so existing employees should have received their notice back at that juncture, and new hires joining organizations should be provided with that notification within 14 days of their start date. And again, the federal government assisted in simplifying this process by basically developing 2 templates. The first template is if there is employer-sponsored coverage available, and the second template is if there is no employer-sponsored coverage. So depending on how an organization approaches the benefits for their group, they would choose the template that applies. And that notification should be provided to every new hire, whether or not they are benefit eligible. So if they're full-time, if they're part-time, if they're going to be a short-term project or contract worker, they still should be provided with that notification. It's not required that someone be benefit eligible in order to receive it. And one of the other interesting features of the marketplace notice is if an employer fails to provide that notice, there is no provision in the law for any fines to be levied against the employer for failing to provide that notification. So that was kind of an interesting choice as this legislation was developed. So let's move to the future. So as we look at a top 10 list for 2014 and beyond, here are the things that your organization may want to be thinking about. There is an employer mandate, and the federal government did include some penalty language for that. And this is to begin in 2015 for large employers. As I mentioned before, for 2015, a large employer is one that has 100 or more full-time equivalent employees. And then we will see that count reduced to 50 full-time equivalent employees in 2016. That again may be subject to change, but that's the projected target at this time. And there are 2 different penalties that can come into play for an employer who does not offer coverage. So down the left-hand side here, we have what they like to call the doomsday penalty, and that is for an employer that does not offer minimum essential coverage, or MEC, to at least 70%. That number increases to 95% of their full-time employees and their eligible dependents. And if one employee goes to the marketplace and applies for coverage and receives a federal subsidy, then the penalty to the organization would be $2,000 per year for each full-time equivalent employee. They do allow a credit for the first 80 full-time employees in 2015, and you'll notice that reduces to 30 employees in 2016. And they do state that that is across a control group entity. So if there's 5 organizations that have common ownership, that penalty could spread across all 5 of those different business entities. There's also something called the bullseye penalty, and that is for an employer that does offer minimum essential coverage to their full-time employees, but the coverage is either unaffordable or does not meet the minimum actuarial value. And if that threshold is met, then the penalty is $3,000 per year for each full-time employee who enrolls in a marketplace and does receive a federal subsidy. So the employer mandate, and with respect to eligibility and marketplace subsidies, if an employer offers coverage, they do need to offer coverage to dependents. Dependents really is more accurately defined as children, because offering coverage to a spouse is not required. Then if they do enroll in that coverage, then the subsidy would not be able to be applied for that family. So if they do go out to the marketplace and they do qualify through their employer for coverage, then they can certainly enroll through the marketplace, but they would not be eligible for any subsidy. Also, there are some reporting requirements, and the reporting requirements are still kind of being finalized, but at this point there are two different sections of the code. At the top of the screen you'll see that there's a section 6055, and this really relates to health insurers or someone who sponsors their own self-insured plan, and it does require that they provide a report of the individuals who are covered by their health plan, and they are also required to provide a statement to those individuals. And you'll see that over on the right, the filing deadline for that will be February 28th of 2016 for the 2015 coverage year. And then when does notification need to be provided to individuals? And that would be same deadline as there is for producing a W-2, which would be January 31st of the following calendar year. You'll also see at the bottom of the screen section 06056, and this does require an employer to file a return with the IRS about the health coverage that was provided by their organization, and again also to provide a statement to the employees that were covered. And again, the reporting date for 2015 will be March 1st of 2016. They'll give you till the end of the month if you do an electronic filing. And again, the same deadline to provide notification to the individuals. And the reason for these reporting requirements is to try to provide some checks and balances for the marketplace and people who may be offered coverage through their employer, but they don't deem it affordable, and they may answer a questionnaire on the marketplace survey in such a way that they end up receiving a subsidy, but in reality should not be, because their employer is in fact providing affordable health care coverage. So it's kind of creating that check and balance to, number one, make sure that the employers who should be offering coverage are doing it, and also to provide that checkpoint for the marketplace and for the information that's entered through the marketplace website or through a counselor. There are some different fees. You may be familiar with all of these. They did come into effect in 2014, and they are generally built into the insurance premiums that you are seeing, because it is the insurance company's responsibility to remit these fees to the federal government. So we have the comparative effectiveness fee, or they call it the PICORI, the Patient-Centered Outcome Research Institute fee. That's $2 per covered life. There's a transitional reinsurance fee, basically to try to help stabilize the market. They realize that the insurance carriers are taking on some additional risk. So that transitional reinsurance fee is designed to help balance that out a little bit. And we've quoted there, it's a $63 per covered life in 2014, then reducing to $44 in 2015. Then there's a health insurer fee. This fee is going to vary carrier by carrier. but the potential increase to premiums is between 1% and 3%. And this was basically designed to help implement ACA across the country. One of the other features regarding plan designs that came in 2014 relates to cost-sharing limits. So the Affordable Care Act basically has stated that a covered person, if they're single, can pay no more than $6,350 out of pocket. If they're a family, that would double to $12,700. So that is the maximum out of pocket that a member can pay. Obviously, if there are payments to a non-network provider or for non-covered services, those do not accumulate toward that out-of-pocket maximum. You might notice, if you are familiar with a high deductible health plan, these are also the out-of-pocket limits, maximums associated with high deductible health plans. For the upcoming year, for 2015, the government did recognize that there are some carriers who use separate systems and separate vendors to do their prescriptions, and therefore they have provided a year of transition relief to allow the carriers to get their systems in sync. So you might see a plan where you have a particular cap associated with prescription and a particular cap associated with medical. Those two combined will never exceed the $6,350 or $12,700 that you see on the screen here. And then what is and what isn't minimum essential coverage? Employer-sponsored health plans, government plans, and other types of coverage that are recognized by Health and Human Services are considered essential coverage. Minimum essential coverage does not include accepted benefits. Accepted benefits do not have to comply with the ACA rules, but they also don't help. So on the right-hand side, we did list some things that are considered accepted benefits. So flexible spending accounts fall into that category, as do limited scope dental and vision benefits, disability coverage, AD&D, workers' compensation, and lastly, employee assistance plans, if they do not provide a significant medical benefit, which generally is not associated with those types of plans. Those are all considered accepted benefits, and you're certainly welcome to offer those, but they are not going to help you meet any type of minimum essential coverage requirements. HRAs, or health reimbursement arrangements, under the Affordable Care Act, if they are integrated with an ACA compliant health plan, then they would be deemed to be acceptable. However, if it is a standalone HRA and an employer offers an HRA without a companion compliant health plan, that may not meet the ACA requirements because it would not provide unlimited coverage, because most HRAs have a maximum on them, and it may not cover the 100% for preventive care that is also required under the ACA. One other legal decision that came out that does factor in here is the U.S. versus Windsor, where the IRS confirmed that same-sex couples, the spouse is considered a spouse for federal tax purposes, even if that couple is domiciled in a state that does not recognize the validity of a same-sex marriage. So that allowed people to add those same-sex partners to their health insurance as a qualifying event, as a mid-year plan change when this legislation changed, if the plan was not already affording coverage for domestic partners or same-sex spouses. And also of that dependent coverage to be treated on a pre-tax basis under a cafeteria plan. Also allowed for those expenses to be eligible under an FSA, and then also allowed those folks to be subject to an HSA limit that would be associated with a married couple. So that helped provide some clarity in that area. The non-discrimination, this has been a long standing part of the ACA, but is still at this point undecided. So the non-discrimination requirements you may have heard as the legislation first came out and as we've been working our way through implementation, basically stated that an employer needed to make the exact same contribution toward benefits for all of their employees. In some organizations today, that the same contribution may be made for similar classes of employees, but not necessarily for every employee across an organization. So we have been keeping a watch on this section of the ACA, and at this point they have not begun the public comment and hearing period associated with the guidance on a piece of legislation. So we are expecting that that will probably be on the calendar at some point in 2015. Then when we receive that final guidance, we'll be in a position to decide, each employer will be in a position to decide how to best implement that to be in compliance with whatever the final legislation states. And then many people refer to this as the Cadillac Tax. This is an excise tax that is proposed to be implemented on high-cost employer health care coverage. It is not scheduled to be implemented until 2018, but it is a 40% excise tax that would be imposed on these high-rich plans, and it is not a tax-deductible tax. So it really at 40% is a pretty punitive number. Right now, they are indexing the thresholds for employee-only coverage at $10,200, and for anything other than single coverage at $27,500. Again, that may be adjusted based on where the cost of health care is in 2018, assuming that this segment of the legislation does still need to be enacted at that point in time. So that one's kind of far out on the horizon, but it is one that has everyone's attention, just based on the fact that it's a 40% tax potentially related to people's benefit offerings. So just also wanted to spend a minute on the individual mandate. So in 2014, every individual in the United States was tasked with, if they did not already have insurance coverage, for obtaining insurance coverage and facing a penalty if they did not obtain coverage either through an employer, through the marketplace, through private insurance. So at this point, this has not been postponed, so it is something that people will need to deal with as they file their 2015 tax returns if they have not already ensured that they do have coverage. But they did need to have minimum essential coverage, and we talked before that could be a government program, Medicare Part A, Medicaid, CHIP programs, TRICARE. It can be an eligible employer-sponsored plan. They can go to the individual market. It may be a grandfathered health plan or some other health coverage recognized by Health and Human Services. We've listed here some exemptions. So if someone has a period in the year where they do not have coverage and it's not more than 3 months, that would be an exemption. It would the cost of the coverage, if it is more than 8% of their household income, if you're not required to file a tax return because your income is so low, if you are a member of a Indian tribe and you have Indian Health Services, and then if you're part of a recognized healthcare sharing ministry, if you are a religious sect that has religious objections that have been filed, if you are incarcerated, if you are not lawfully present in the United States, or you suffer a hardship as defined by Health and Human Services. So we've listed some of these hardship exceptions here. It can be that you filed for bankruptcy, that you were homeless, that you have been a victim of domestic violence, you have a utility shutoff notice. There are different categories here that are outlined by Health and Human Services. I'm not going to go through each one of them in the interest of time. And then to look at the penalty that could be assessed against an individual. The penalty is calculated monthly, and it's based on either the flat dollar amount or percentage of household income. It can be assessed against each person within a household that is not covered. So we do say that there's a flat dollar amount for a child under 18 is half of the adult rate, and then the total flat dollar penalty for any household is 3 times the annual flat dollar amount per adult. In 2017, we expect that these will start to be adjusted for cost of living, but you will see the 2 charts here that do provide the flat dollar amounts or the percentage of household income. The concern has been that a $95 a year penalty may not be enough to get some people to enroll in insurance that may cost them more than $95 per month. So, to kind of sum it up before we go into the question section, now what? So you definitely, as an organization, need to be building your healthcare compliance strategy. And when you're doing that, the questions you want to ask is, what does your organization have to do, by when, and what options are available to help you satisfy those requirements that are applicable to your particular group. So Veronica, I'm going to actually turn the presentation back over to you.
Thank you, Marla, very much for that presentation. I'm going to go ahead and get started with sharing the results. In the meantime, if any of our attendees have any questions, please start typing them in so that we can get those answered for you. And here is the first question and answer. And Marla, if you want to touch on that a little bit, please do.
Okay. If I am actually not able to see the poll question, so if I could just ask
Oh,
you
I'm
to
so
repeat
sorry
it
about
for me.
that.
That's okay.
The first poll question is, if I have under 50 employees, do I have to worry about Affordable Care Act? And
okay. What did the poll say?
The poll, we have 57 say yes and 43 say no.
Okay. So I'm going to say that there is, I think you definitely have to be aware of the Affordable Care Act, regardless of the size of your company, because there are certain elements that are not dictated by the size of an organization. And the 2 items that are currently in effect, the summary of benefits and coverage, as well as the marketplace notification, apply to all employers regardless of their size. There are other areas where smaller employers that do have less than 50 worksite employees will not be impacted in terms of employer responsibility and things like that. But I think because organizations grow and change and can merge, may be part of the control group, it is always best to be aware of what is happening in the ACA.
Great, thank you. I'll bring up the next question. Next question, what is the penalty for not providing ACA compliable plans in 2015 for companies with 50 through 99 full-time equivalent employees? The first choice was $2,000 per full-time employee. We had 40% answer there. $0, 0% answered. $3,000 per full-time employee, 0 answered. $2,000 per full-time employee minus the first 30 full-time employees. We had a 60% answer that, D.
Okay. I like answer D in 2016. In 2015, if you do have 50 to 99, you do get a larger credit on those employees for that first year. So in 2016, it would be less than 30, but they did give a larger credit in 2015 as, again, part of sort of that transition relief to kind of help ease everybody who might not be in a compliant position to give them a bridge year to get to that.
Okay, great. Thank you. We do have a question here that came in, and let's see. What about employers with less than 50 employees?
So if one of the things that you want to look at about your organization is make sure that there is not a control group, so there isn't a sister company or a parent company where there is a controlling interest where you might be aggregated. But if your organization is under 50 worksite employees, you do not have a requirement under the ACA to offer coverage to your employees and to make it affordable. You do not face any penalties at this point in time as the legislation is written if your organization remains under 50 worksite employees.
Okay, great. Thank you very much, Marla. Doesn't look like we have any other questions that have come in. If that's the case, then I think we'll go ahead and conclude the webinar. I just want to thank everybody again for your attendance. If you do think of any questions, please email me, Veronica, at partnersdocs.com, and I can forward your questions to Marla if you have any questions that come up at a later time. We will share this PDF on the PRC website, and we will also email it to all of our attendees today. Again, thank you very much for your participation. Thank you, Marla.
Thank you.